Okay, so I'm just going to share these slides. Okay, take it away.
All right, good afternoon. My name is Corrine Baser. I'm a manager in the Quality Division at Ontario Health, and I'm really pleased to be here today with everyone. I know this is a very dedicated group of clinicians and leaders who already are focused on hip fracture care, and so really pleased to be able to share Ontario Health's commitment and our 3-year strategy to support your efforts that you already have on your way and to help spread and scale what is working. I'm joined by my colleagues Cheryl Kennedy and Dana Summers, who will also be presenting in this upfront portion of the community of practice today. They'll introduce themselves as they go into their sections. I will also just flag that we've got a very capable team behind the scenes that go beyond just the 3 of us presenting, and a big thanks to all of the collective effort from the Quality Division that's gone into pulling together this strategy. Next slide. Oh, and last but not least, a big thank you to Dr. Jang Singh, who hopefully everyone knows by now is Ontario Health's clinical lead for hip fracture. So, her support, her championship, and her passion for this work, and for the time in this forum to share. So today we'll just walk through a couple of different agenda items. I'm going to start by presenting, a bit of a review of Ontario's hip fracture data. We'll walk you through the 3-year hip fracture quality standard implementation strategy with a real focus on what are those priority clinical areas or clinical statements from the quality standard that we want to draw people's attention to as they continue or start or continue the work. And then also touching on what are some of the provincial supports and the existing quality improvement efforts that are advancing improvements to hip fracture care. And then we're going to get a bit interactive with the group and give you an opportunity to provide feedback on the draft change ideas from the hip fracture implementation toolkit that we're hoping to release in December of this year. So we want to really make sure that resource is helpful, draws on your expertise, and helps to, again, spread and scale what is working and what is evidence-based. So just to flip forward to another slide, to set the context for this work, would like to share some data that highlights where the issues are that need our collective focus. Next slide. So, why should we be thinking about hip fracture care? Well, first and foremost, we all know we have an aging population, and this is a condition that predominantly affects seniors. So we know that over the next 20 years, the Canadian seniors population is going to grow by 68%. And given that hip fracture increases with age, it's safe to say we're going to be seeing a lot more hip fractures. So from a system and demographic perspective, the numbers are going to go up, and we know from other jurisdictions like the UK that we really need to get ahead of it. Next slide. From a hospital perspective, it's a huge resource allocation issue, given that this is a common injury already in older adults. So we see somewhere upwards more than 10,000 per year in Ontario, and those continue to grow year over year. In fact, in Ontario, hip fracture repair is the 4th most common diagnosis for admission by volume. And it is one of the most expensive admission diagnoses, $23,000 per case in hospital, with additional non-acute care costs during the first year post-surgery. So again, from a system perspective, high implications. It's also disruptive to the day-to-day operation of the hospitals. So we need to be thinking about protocols and consistent data collection to manage this growing problem. And of course, last but not least, we know that proper care will get seniors through the event, and bad care can lead to increased mortality. So this is all the reasons we're focusing on this issue. Next slide. So just looking at some of the provincial performance on one of the core statements of focus for the campaign, and that is around surgery within the 48-hour standard. So you can see here across the 6 regions of Ontario Health, we're averaging around 77% of patients making it to surgery within that 48-hour benchmark. There is variability across the regions. You can see some are trending up, some are trending down, but overall, I think we've highlighted the performance of our peers, including some other provinces like Alberta, who are at around 82%. And then if we look at and get inspired perhaps by some of our European comparators, there's a huge opportunity to raise the bar in terms of what the expectation is around the numbers of percentage of patients we get to surgery in a short amount of time. I will just flag that for some of you who have delved deep into your data in the e-report, we've made some refinements to the wait time indicator, so you may observe a difference between the data here and in the e-report. In its current state, there will be a new release of data soon. So if you see that discrepancy, that's why. If we go to the next slide, this just drills down a little further into the variability related to the 48-hour surgery benchmark. And, you can see on the left side that there are some hospitals that are performing extremely well, up probably high 80s, low 90s in terms of performance. But we also have 18 that are below the provincial average, so a lot of opportunity for improvement. And then, just quite a few in the middle that just I think we can highlight from our comparators have an opportunity to continue to increase that performance. Next slide is around 30-day mortality, again, highlighting the variability in performance across the province. From the best performing hospitals, probably around 2 or 3% of patients passing away in the 30 days post-surgery, up to nearly 10% for some of the lower performers. One of the things we've highlighted is that in many cases, if you drill down into the data, you start to see that those that are above the provincial average of in terms of mortality rate have a median wait time that is much longer at above the 48-hour mark. Next slide really speaks to the impact of hip fracture and the opportunity for enhanced flow. So again, we kind of know that a large percentage, 36% of patients that have hip fracture surgery in Ontario end up having some kind of ALC length of stay. This is what this particular graph maps. That for hip fracture patients with ALC days, many of those are fairly low, 1 or 2, or the average is actually around 5 days. But if we look at the tail end of that graph, we're looking at stays of upwards of 10 days, 15 days, 30 days, I'm sure I'm preaching to the converted here when we know that that's a huge pressure in hospitals. So huge opportunity to reduce overall length of stay and, of course, improve the experience for patients. Next slide. So last but not least in this sort of section around data, this is obviously not quantitative data, but speaks to the experience of patients who have gone through hip fracture. And so I'm going to read this and I'll just comment generally that, my active 79-year-old dad used to walk 20 to 30 minutes daily for exercise. One day he tripped and broke his left hip while out on his walk. Although he received fixation surgery quickly, I was surprised to hear that he wasn't allowed to put weight on his leg afterward. His surgeon said the bone quality was good and the surgery went well, but was still restricted weight bearing. This delayed rehab and made recovery difficult. Despite being active and strong before, my dad struggled to regain his independence, and I believe this contributed to his health decline over the next year. Better education and adherence to Ontario Health Quality Standard, which recommends weight bearing as tolerated, could help patients recover faster, get moving sooner, and give them the best chance to return to their lives. So this is the experience of a caregiver family member, Patricia Dixon, who's also part of our advisory group, and I think really highlights that, that post-op care is critical. We don't, I will say at the moment, have great provincial data on weight bearing as tolerated. It is a data focus that we're going to be looking into as part of our strategy. But I will turn it over now to Carol to speak to the strategy and where weight bearing fits into it, amongst other areas of focus.
Great. Thanks so much, Karina. I'll just briefly introduce myself. I'm Carol Kennedy. I'm a lead in the Clinical and Quality Standards Program at Ontario Health and working to support implementation of the hip fracture quality standard with our team here at Ontario Health and a provincial advisory group that we've brought together from across the regions in Ontario and representing a wide range of perspectives on this group. Next slide, please. So why we're focusing on hip fracture now? Ontario Health updated the hip fracture quality standard in 2024. It was first produced in 2017, and we've recently updated it. We know there's been a lot of work in the past on hip fracture care. The Bone and Joint Canada has published a toolkit. We've got the quality-based procedures published in 2013. But hip fracture needs to come back onto the radar as a priority for many hospitals with improvement potential. Data shows substantial variability in quality of hip fracture care across the regions, which we've seen a little bit of that snapshot today. And there's lots of opportunities for improvement across organizations. By supporting hospitals with data, tools, and training, this will promote quality and equity in surgical care for older adults. And focusing on priority clinical areas will target improvements to patients' outcomes, such as reducing mortality, time in hospital, and readmissions. Substantial improvement is possible, and we've seen examples through London Health Sciences Centre, where we've highlighted through a spotlight report, and there's a QR code here, and we'll put a link in the chat today of that spotlight on London Health Sciences of how to implement the quality standards through timely surgery and enhanced postoperative care. Next slide. So implementation will be an iterative journey. Here at Ontario Health, we've mapped out a 3-year roadmap for hip fracture improvement. We're just starting now, so we're at year 1, and we're starting with engagement and planning with early adopters and leaders in acute care and emergency departments to confirm clinical priorities, build hospital-wide awareness, align system goals, and establish provincial supports. In year 2, our goal will be to continue implementing and coordinating the plan that we've outlined through launching and testing acute care change ideas, piloting digital tools, and exploring barriers to inter-institutional transfers. And finally, in year 3, we'll focus on spreading and scaling up these successes to expand successful practices across acute care and develop sustainability strategies. Next slide. So this slide speaks to the hip fracture areas of focus for quality improvement. The quality standard, which includes 15 quality statements, and we'll add a link to the quality standard in the chat if it hasn't already been added. But we're going to focus on 6 of those 15 quality statements, and those are the ones highlighted in orange here, which we've prioritized as the first ones will target and share change ideas to galvanize system efforts. We recognize that hospitals and regions have lots of priorities, and as we plan for year 1 activities, we are conscious of how this work aligns and can build on existing work along the way. And these all contribute to core system and hospital priorities, and we've listed some of those on the top line in blue, of improved hospital flow, shortened length of stay and alternate level of care, and preventing unnecessary admissions. So going to the next slide, here we've shown many provincial supports and implementation levers that we will be working with to align our activities around. The next couple of slides will briefly highlight some of these levers or implementation levers. And I will note that alignment with the quality-based procedure strategy has been highlighted to us with many of our engagements as a key opportunity to explore and to engage going forward with the ministry and internally to see, how we can, improve quality within and use the quality-based procedures to support this work as well. Next slide. Our team presented in the spring at ECHO and when the e-report was released, and it's now been out for 2 quarters. And we hope that everyone is now aware that at both regional and organizational level, there is data to guide decision-making around quality improvement opportunities. We've met and started to meet with all of the regions at this point to share our review of the regional data and where we've identified recommendations and highlighted where there's potential for improvement across the regions. As Corinne mentioned, the e-report will be updated then with the next quarter, and it should be updated by October 20th. We've refined some of the data in the wait time to surgery indicator, so you may see some changes to those results with this refresh. And just wanted to also be clear that the e-report is not tied to funding. It's really a tool there for organizations and the regions to use to support ongoing quality improvement efforts. Next slide. So we want to ensure that all regions and organizations know that targeted guidance is coming through the Hip Fracture Quality Standards Implementation Toolkit. This toolkit will give clear change ideas to implementation and supporting resources. We're working on this now, a lot of engagement with our advisory group. We're going to be sharing some draft change ideas with you later in this presentation. And the goal is to release in early December of this year. The link here, the QR code, and we'll put a link in the chat, is to another toolkit, the Delirium Awareness Campaign or DASH Campaign Implementation Toolkit, just to give you an idea of what's coming for hip fracture. Next slide. Another provincial support that we have is the Ontario Surgical Quality Improvement Network. It's a critical lever for this work, and they have a mandatory network for all hospitals that perform over 5,000 surgeries per year. OnSquin is a community of practice that includes 52 hospital sites, and the program focuses on measuring surgical outcomes, identifying risk factors, and implementing quality improvement initiatives. And you can learn more about that, the OnSquin and the program evaluation that was done. We'll put a link to that evaluation in the chat today as well. As well, another lever that we have is Evidence to Practice, or E2P. It's another provincial support whose mission is to translate quality standards and clinical practice guidelines into decision support tools that are digitally embedded in frontline clinical information systems. And we'll as well put a link to their main website for organizations that are interested in being involved. There's a link for expressions of interest. And finally, Ontario Health 2026-27 Quality Improvement Plan program is proposing a new indicator related to hip fracture that will be finalized and announced in November. Associated change ideas will focus on standardizing and streamlining the hip fracture care pathway, prioritizing surgery for hip fracture patients, ensuring regular review of hip fracture data, and building capacity to develop an interprofessional approach to quality improvement in hip fracture care. And next slide. this summarizes our timeline and action plan or key activities over the next year or the first year of this work. And if you look at where the star is, we're in the last 2 quarters of this year. We're focused on early engagement and bringing together the clinical expertise to drive this work, which included hiring and bringing on a clinical lead for hip fracture and pulling together an interprofessional provincial advisory group. As we move from October to December, this is where we are now, and the work really is starting to we're really getting the work going with release of the QIP indicator and developing the toolkit. And then as we move through the rest of the year, we're going to be working very closely with the ECHO community of practice to focus its sessions on clinical areas of focus that are covered in this initiative and featuring change ideas and organizations who are starting this work so that others earlier in the journey can learn from their successes and challenges. And finally, for organizations that want to get started and are interested in implementing the quality standard, a few steps, and again, you'll see some of these steps were followed by London Health Sciences Centre in the Spotlight report. Engage leadership and secure buy-in. You can use the e-report to access current performance, identify gaps, and build a case for change going forward. We encourage you to build a committed team and begin assessing current practices. And then step 3, use provincial supports to guide your quality improvement journey. And we've shared a number of those supports today, and we can share the deck as well and the links following today. So I'll pass it over to Dana Summers, who will go ahead to the next slide, Jenny, and Dana will be leading some discussion around the toolkit and feedback.
Thanks, Carol. Hi, everyone. I'm Dana Summers. I'm a Senior Specialist in Quality Improvement at Ontario Health. And we'd like to take a few minutes now to get this group's feedback on the content that we have developed so far for the Hip Fracture Implementation Toolkit, which is, as Carol just mentioned, one of the resources we're developing to support the 3-year hip fracture strategy. So with Dr. Thane and Dr. Frieder's leadership, Ontario Health, next slide, has been working with an advisory committee of experts to identify practical strategies or change ideas that can help hospitals make progress in implementing the 5 priority quality statements. And so we started with an initial list of over 160 change ideas, and we've now refined it down to about 15 change ideas that we really think can help make hospitals make meaningful improvements based on the evidence as well as the experience of those who have already made strides in these areas. So once we finalize the change ideas, our next step then will be to identify tools and resources that we can share related to those change ideas. So for example, many of the, for each statement, clinical pathways and order sets that are standardized and include key elements have been, are one of the important change ideas we've included for each. And so where other organizations have already made work in this area and have developed something that meets all of these elements, we're really to be able to share those resources with the province. And so we hope that some of you may also have resources that you'd like to share, and we will talk about that at the end of this presentation. Now, recognizing that there are quite a few people on the call, the most effective way we could think of to collect your feedback is to invite you to take a few minutes reviewing and rating the draft change ideas for their feasibility in a survey, and we'll be sharing the links with you to those surveys shortly. So next slide. So on this slide, this is just a zoom in into the DASH implementation toolkit, again, to give you a little bit more of a sense of what we're trying to develop here. And I realize it is quite small to see, but on the right-hand side, there are change ideas in the left-hand column there that are related to building awareness and the culture of talking about delirium. So there's change ideas listed there. And then also you can see that there are a couple of links to tools. I think it's the delirium triage screen and also the confusion assessment method. sorry, it's really slow for me to see. And then on the in the right-hand column, we have the process measures. So this is what we're hoping to develop. So we've identified the change ideas we intend to include. Next slide. And so I'm just going to start walking you through what those change ideas are. The first priority area focus is surgery within 48 hours. So the quality statement says people with hip fracture receive surgery as soon as possible within 48 hours of their first arrival at any hospital, including any time spent in a non-surgical hospital. And the change ideas on the next slide that we have identified that we think can make a difference in this area are, I'm not going to read them verbatim because you will see them in the poll, in the survey that we're going to open in a moment. But generally the themes are, the first one is around standardizing care through clinical pathways, ORSF, et cetera. And there's a few items underneath it here that we think a standardized pathway would need to include, and we're asking for your feedback on that. Then we look at getting patients into the OR within 48 hours, and those ideas are around the urgency, with the booking urgency. Then we've got an idea around dedicating blocks of daytime operating room time. And then the last idea is around initiating regular interprofessional reviews of the data. So on the next slide, we would like to invite you to open the survey. So here's a QR code, but also we're sharing the link in the chat, which might be an easier way to see all of the change ideas. It just depends on your preference. But we would like to invite everyone to open that now, and we'll give you, let's say it's quite short. So let's start with 3 minutes to complete that, and then we'll check in at the 3-minute mark to see how people are doing. Yeah, so let's do that now. Thank you, everyone. Okay, that was 3 minutes. How are people doing? Can I see maybe with the thumbs up reaction if people are ready to move on? Okay, good. Okay. It's hard to tell how long it will take people to think about each question and respond. So it looks like we're on track. Okay, so in that case, then let's move on to the next slide. Okay, so the next quality statement is number 8, weight bearing as tolerated, and it reads, people with hip fracture are mobilized to weight bearing as tolerated within 24 hours following surgery. And then on the next slide, daily mobilization reads, after surgery, people with hip fracture are mobilized on a daily basis to increase their functional tolerance. So for these two quality statements, we put them together because when we were looking at that initial list of 160 change ideas, there was a lot of repetition and overlap in the change ideas related to these two topics. So we've put them together. So on the next slide, the themes that we can see for this one include, again, standardizing care through clinical pathways, order sets, and medical directives. Then we have about 8 items underneath the theme of maximizing patient mobility. And we're going to be asking you about the feasibility of each of these elements. Then the next one is on increasing PT and OT capacity, so making sure there's coverage 7 days a week. And finally, clinician education, so ensuring that everyone understands just how important weight bearing is tolerated and mobilization benefits are. So on the next slide, we have another survey. There's 3 surveys in total, just so you know how long this is going to continue. And Sylvia has once again put the link to the survey in the chat. So I will set the timer again for 3 minutes, and thank you so much ahead of time for your participation. Okay, just checking in again. Where are we at? Are people ready to move on? And show me with a thumbs up if you like. Okay. All right, looks good. Okay, so last statement. Oh, I should mention the reason we're not asking about quality statement 10 is because the DASH implementation toolkit already exists. So we're just going to use that in lieu of asking for new change ideas related to WAM. Okay, so next slide. So for quality statement 14, osteoporosis management, while in hospital, people with hip fracture undergo a fracture risk assessment from a clinician with osteoporosis expertise, and when appropriate, are offered medication for osteoporosis. And so the change ideas related to this one, on the next slide, are adopting a 3I model of care, and then the standardized therapy, so related to creating that pathway and order set that includes, we have a few items under there. Then anti-resorptive therapy, and IV zoledronic acid, patient and family education, and then finally discharge planning for bone health management. And so on the next slide, we have our last survey, another 3 minutes, and then we'll move on. So thank you so much for your patience in doing this with us. Okay, I'm setting the timer one last time for 3 minutes. Okay, just check in again if everyone is ready to move on. Okay, thank you so much everyone for that touch point. We're really looking forward to reading your feedback. And okay, last slide. So in terms of next steps for the implementation toolkit development, based on the feedback that we received today, we will be finalizing our list of themed ideas, and then we'll be looking to link each of those themed ideas with resources. So if you know, as you read through those themed ideas today, if you know of things that you would like to share, please let us know. You can put your name in the chat. And similarly, when we finish compiling the themed ideas and the tools and resources, and we've drafted the toolkit, we are hoping that people from this committee would be, or from this committee of practice would be interested in taking a look at that before we launch and providing feedback. So if that's something that you're interested in doing, we would love for you to put your name in the chat and connect with you. I see comments coming in, so thank you already. And yeah, all right, thanks so much. That's everything from us. Oh, and if you have questions or feedback, here's our address. Back to you, Denny.
Great. Thank you so much. I was just trying to unmute myself there. So thank you to the whole team at OH for all of that great work that you've done and for sharing with us what the plan is going to be over the next few years. I'm just going to take some time and open up the floor now for questions and answers. If anybody has any questions for the team. I saw that there were some questions in the chat already, which we have hoped to answer. If you need anything further clarifications, please let us know. Just having a quick look. I can see there's a question about will quality statement 13 be addressed as part of this?
I'm happy to speak to that, Jenny. Sorry, I was actually writing a response, but happy to share it more broadly. So as we discussed today, the initial 5 statements of focus for the provincial work and the toolkit will be 2, 8, 9, 10, and 14. This could expand in future versions of the toolkit, but we did want to keep the work sort of scoped in this first year. That being said, as you as a hospital with your teams, as you sort of initiate work, if you're starting it or if you're continuing work, if you identify that there are gaps between the current standard or the quality standard in your current practice, and it highlights that 13 is really important or particularly important, then we're certainly not saying don't focus there. We truly believe that to improve quality of care for patients, that it requires multiple implementations of different statements. So nothing's stopping you. We just wanted to keep the focus provincially a little bit scoped on those priority areas.
Great, thank you, Corinne, and thank you to so many people for continuing to volunteer to engage and review. So that's really wonderful to see. There's another question in the chat from Dr. Sherilyn Kane about great to incorporate osteoporosis management. However, 99% of people that have fractured have done so because they've had a fall. Will the fall's quality standard be linked to this quality standard?
So the falls quality standard is just getting started. We certainly recognize the interconnectedness between fragility, falls, and hip fractures. So absolutely think that in future, once we have those quality standards, we'll be certainly thinking about how we can take sort of maybe a holistic look at those populations. So I think that is absolutely in line with sort of the integrated approach that we take around quality standards implementation and trying to identify some common themes and opportunities across this kind of population. So we obviously don't have it yet, but yes, I think that is safe to say that we would be thinking about them together.
Fantastic, thank you. And then a question from Megan Kelly. Can you elaborate on the change made to the indicator for time to surgery? We're trying to ensure our internal reports align with yours.
I'm wondering, Catherine, I know Catherine's on the line. Do you want to speak to that question?
Sure, yeah. There wasn't really a change made to the methodology in terms of the start and end times. We had just
refine the calculations to use a more accurate timestamp. And so what you'll see later in the October 20th refresh is just the update to the data itself rather than the methodology.
Okay, thanks, Catherine. So hopefully we'll be able to see those updates, and I believe it's the beginning of October, that next iteration, the e-report data will be available. Leanne Stacken has asked, can you comment on whether the new standards is reflective of any current standard and or is it brand new?
I'm happy to, the update of the hip fracture quality standard was an update from 2017. A fairly light update. You know, we looked for new guidelines and any changes to the evidence, but really we didn't, there weren't new statements or topic areas. It was really more just to make sure we had the most current evidence supporting the quality standard. We'll do another update at 10 years. So every 5 years we'll be doing updates. And that one will be more fulsome. We bring together the whole committee, a new committee for that. So.
Great, thanks, Carol. And Camilla Wan asks, have you engaged implementation science experts regarding development of tools and processes for implementation knowledge translation?
I'm happy to speak to that. Oh, unless someone else wanted to speak to it. I really appreciate this question because within the quality division, we've actually engaged implementation science experts in helping actually to train our team more broadly to understand how to embed, those core concepts into our work and into how we approach implementation at a system level. I can't say right now we've directly engaged them into tool development, but certainly, both concepts of QI, change management, and implementation science underpin the work of the quality division and, are emphasized when we hire and train our team members. So hopefully that helps to answer.
Okay, thanks, Corinne. And just to recognize that was Marjolaine's question, because she's joining us at the moment. Okay, great. So I don't see any more comments in the chat. Are there anybody want to ask any questions out loud? If not, I just wanted to give a huge thank you to the Ontario Health team. I believe the plan is for you to come back again at the beginning of December once the implementation toolkit has been created, and they'll be able to share with the group here what the final project is going to be, and hopefully be able to engage us in spreading the word to our organizations as well. So thank you very much to everybody who came from Ontario Health. So we are very fortunate today that we have Dr. Hans Kreter, who's going to be speaking and talking about some patient cases. But just before Dr. Kreter comes on, I'm going to make a couple of announcements, if that's okay. I can see you've unmuted yourself already.